Welcome to today's special episode of Peer2Peer podcast by Rayner. I'm Dr. Ben LaHood. Today, we'll explore not only the key milestones in IOL advancements over the past 75 years, but also how innovations like Sulcoflex embody our commitment as surgeons to integrating cutting-edge technologies into our practice to improve our patient outcomes. First up, we've got Professor Amon, Head of Department of Ophthalmology at the Academic Teaching Hospital of St. John and Chair for Ophthalmology at Sigmund Freud Private University. Welcome very much, Prof. Amon. Thank you so much for chatting today. What have you been up to so far in 2025? How's it treating you?
Thank you. I had a good celebration during Sylvester, and I thank you for the kind invitation. I think it's an interesting topic, and I'm looking forward to answer this question and discuss with you Australian surgeons. It's a pleasure to meet you here in Vienna.
Awesome. Thank you. I've been to Vienna for the ESCRS meeting. It's a beautiful city.
Thank you.
So, Prof. Amon, I understand that the first Sulcoflex lens was implanted in 2007, but I'm sure that the innovation went a long way before then, before you were putting one inside an eye. We'd love if you could start by reflecting on your journey in developing and bringing some optical technology to the market.
Yeah, it was quite a long journey. It started 4 to 5 years before 2007 when I first had the idea. It arose because we had always the problems of post-surgical surprises, biomedical surprises. In that years, more than now we have, because we had different formulas and so on. And at that time, there was no good solution. To explant is one solution, to do a laser refinement is another. But I thought, wouldn't it be nice to specially design a lens for the sulcus with a certain design that doesn't make all these problems with lens exchange. So for that reason, I had this idea, and I made some drawings. And with this idea in mind, I went to Rayner company to ask if they are interested to design a lens with me for that special purpose.
Yeah, I'm so glad that you came up with the solution because I'm a chicken. I don't like exchanging lenses. I love being able to put a sulcus lens in, so thank you.
Thanks.
And then we've got Dr. Michael Rossiter Thornton, anterior segment cataract cornea refractive surgeon from Sydney, Australia. Michael, you are the first true Australian on the show. I think Graham Barrett is really from South Africa. I'm really from New Zealand, but don't tell anyone. I don't want to get kicked out. We've talked a lot about sulcus lenses, just the two of us, but you're an expert in sulcus lenses. Does that mean you're creating a lot of residual refractive errors?
Not at all. No, it never happens to me. Never, ever.
Good,
No,
excellent.
I think you're hitting the nail on the head. It happens to all of us, and it's so good to have a simple way of fixing it, which is what the Sulcoflex allows us to do.
Michael, building on Prof. Amon's opening, can you share your experience with IOL advancements, how you began using Rayner lenses in general, especially the Sulcoflex lens, and I suppose, what excites you about using these lenses with patients?
Yeah, so I got started when I had a patient who had been pseudophakic for many years with monovision, and she was unhappy with the disparity in vision between her eyes. She had neighbors who never needed glasses, and I came to her and said,
Always. They always have a neighbor. There's always a neighbor that
absolutely,
has a perfect outcome that doesn't need glasses, and you have no idea what they had.
exactly,
Sorry,
exactly.
I just had to have a rant there, but carry on.
No, that's why I said it. That's why I said it. But I basically said to her that I can give you multifocality, which she was very keen on. And I talked to her about Sulcoflex trifocals, and she went ahead with the surgery. And she wasn't over the moon with it, but she was much happier with having multifocality than she had been with having monovision beforehand. And her experience was informative because, as I think we all know, if a patient goes from having a monofocal lens to having a diffractive lens, when they've experienced both, then they're aware of the contrast decrement. But she was quite happy with the fact that she now had multifocality.
And so your first entrance into sulcus lenses with the trifocal. Quite I think most of us have probably used it for just a pure spherical refractive area to get started, but that's a gutsy start.
But it was a clever way, I would say, because it is a reversible technology, you know. You can put that lens in, and in some cases you may them to take them out, you know, and it's a reversible procedure. So that makes sense for such a special patient with monovision, unhappy monovision patient, or even in cases where do a cataract and to primarily implant that lens in a do-it way, in a do-it procedure. Yeah. So because you always have a way back, you can always step back if there is some dysphotopsy or whatsoever.
I agree. I always think the people that do the duet procedure, Prof. Amon, are chickens and they should just commit to the trifocal. But I do respect that, you know, there is, for people like me that don't like taking lenses out, if the people are a bit on the fence, it's a very good option.
I think it is because there are also some Heidelberg works who showed that the optical performance is absolutely the same. So you have almost no disadvantages, almost no. There's never, you have to put 2 implants in. That's right. But optical speaking, it's no difference. So for me, it makes absolutely sense. And I think you are not a chicken if you implant the lens within the same surgery.
I agree. Prof. Amon, how important is collaboration in developing a new IOL technology?
I I was looking for a company who had a hydrophilic material on their stock because if you put a lens in the sulcus, you have a direct contact to UVL tissue. And it has been shown that UVL is advanced or better in hydrophilic acrylic than is compared to hydrophobic acrylic. And so I stay with Rayner because they really did a wonderful job in developing Sulcoflex and doing a trifocal and toric version of this platform. Yes.
And Michael, when you're looking at new technologies, you know, such as when you were thinking about using the Sulcoflex lens, how do the manufacturers like Rayner build trust? Are you looking for sort of KOL celebrity endorsements, or are you looking for the study data, or are you just watching my Instagram?
I have to be honest, it's definitely that last one, Ben. Seeing if you've done it before, and then I'm good.
Okay.
That's the key. But how do the manufacturers build that trust? I think it's when they approach it with the same humility that I think we should approach it when we're treating the patients. Talking about its strengths, its weaknesses, the problems that other people have had. Because as you said, Professor Amon, nothing is perfect, nothing's without compromise. And I think being upfront about that is the key. If something is promised to be perfect, we know it won't be. And so that's how they get me.
I think it's also important to have some peer review work on that type of lens you use. I feel much more comfortable when I use something new that there are some data available. Sometimes it's not available if you're one of the first surgeons, definitely. Then you have to trust and to believe to other colleagues and the company.
Was that hard to come up with, Prof, when you were first developing the lens? Was it, you know, because we don't, it's not a lens that we implant a lot of all the time.
That's right.
So it must have been hard initially.
It was not so easy for the ethical committee to convince them that it is a good thing to do. It was hard to collect the patients for ametropical, for surprises. It's not so many patients you get. And so for that reason, in the very beginning, it was hard to collect them. It was easier with do-it procedures because for refractive reasons, you have more patients to treat and to follow up as compared to ametropic. So in the very beginning, it was hard to create a good number for statistical analysis and to get a peer-reviewed publication. Yes.
And in terms of the need for supplementary sulcus lenses, Prof. Amon, when I think of refractive errors, maybe because I also do laser surgery, if I find a myopic error, I'll often think about laser before a Sulcoflex lens. But a hyperopic error especially, I find them particularly useful. And we spoke about the duet procedure. Are there any other uses for the sulcus lens that you've come across or that you've developed?
Definitely, yes. For instance, in cases with dynamic refraction, in pediatric cases, I did it because, you know, when we implant a lens, then myopic shift occurs in all the patients. The earlier you do the surgery, the more it will happen. And then I sometimes even can adjust the refractions for the patient. So I have some patients where I did an exchange of the Sulcoflex for 2 times because I wanted to keep the patient in a more or less ametropic or shortly myopic area. So refractive changes, dynamic changes, PKP, for instance, corneal diseases where you have a change, silicone filled oil eyes, where you have a hyperopic defocus created. So in all these cases, I think add-on lenses make sense and they are helpful, and you can change that and exchange that. And for that reason, I think it's a very nice tool, not only for surprises or for do-it procedure, but even for special cases which you have in your office.
That's really true. I've also used it for negative dysphotopsia quite successfully. Yeah.
Did it help? Yeah. I did that too. It's not helpful in all cases, but I think in quite a lot. About 70%, I would say it helps. Yeah, it's good. Yeah.
Yeah, I mean, just putting it sounds strange, but putting a zero power Sulcoflex lens I know that we don't fully understand negative dysphotopsias, but that did seem, for my cases, it did solve the problem.
Oh yeah, that's good to hear. Yeah.
Yeah, and Michael, are there any specific situations where you find the Sulcoflex lens particularly effective?
Well, I've used it a fair bit for negative dysphotopsia, and my experience has been much like yours, Ben. It's quite effective. Not always, as you say, Professor Amon, but it's a really nice technique to fix a problem that can be really intractable for some patients. The only thing I'd add is that for a couple of select patients, I've induced quite extreme monovision to get rid of diplopia. Patients in regional areas who don't want to travel to see a strabismus specialist, they're already pseudophakic, so you can establish with a contact lens trial that that degree of monovision will be satisfactory for them, makes them happier. And amongst the happiest Sulcoflex patients I have are those I've given that kind of monovision.
That's a really smart move because, generally we're taught strabismus don't give monovision, but you can use it therapeutically.
Yeah, in select patients. Yeah.
Cool.
And Prof. Amon, we started the podcast by talking a little bit about your journey with Rayner and how you developed this lens. You spoke just before about a hydrophilic material being more uveal compatible. Can you talk a little bit more about the process, the challenges, the successes, how that actually worked? Because I think very few of us have actually come up with a design and seen it through to market.
Yeah, it's this lens is quite thin usually because you don't correct high ametropias, only small ones, or if you have diffractive trifocal lenses, you need a very thin one, and the posterior surface has to be concave. So you have a meniscus-shaped lens, which was not so easy to design for the company. It was thin, and then we had to try to find an optimal haptic if you need an angulation to get a uveal clearance. Fortunately, finally in 2007, it was the first implantation. And this was I still remember, it was a ametropic, highly myope patient. So I thought there was enough space for that lens. And it worked nicely. And this patient still has the lens in his eye, in her eye. It's now 18 years almost. Yeah. So I am now convinced that that lens fits in the eye, even in small eyes, and that the design Rayner and I developed is working nicely.
That's awesome. Speaking of having room inside the eye for the lens, when a patient is pseudophakic, I've got to admit, I don't really worry about the dimensions of the eye. I just imagine the sulcus lens should fit. But are there parameters that people should look at about whether a Sulcoflex would be suitable inside the eye?
Anatomically, I would say from the size, it fits in almost all eyes, even in small eyes. And the lowest axial length was 15 millimeters. So I think the anterior chamber depth is not a big thing to say to tell the truth. But I think it's important that you don't use it if you have some zonulopathies, if you have some very high myopia with some zonulopathy, if you have PEX eyes. I would not suggest to put a sulcus lens in these kind of eyes. But the dimension of the eyes, in my opinion, the haptics are very floppy, very soft. Yeah, the diameter is 13.5 millimeters, so it fits in large eyes, and it also compresses and fits in small eyes with a white to white distance, which is small either. So I think the anatomical shape of the eye is not important, but the pathological situation of the eye is very important.
Oh, that's really nice. It's nice to hear from the inventor himself. That's really good. Uh, Michael, we should address the other lens that's on the market. There is another sulcus option. There's the add-on lens, and you and I have had a few private conversations about using it, and I use it fairly routinely. But both of us have had some troubles deploying it and getting haptics caught. I posted some videos online about the add-on lens and getting a haptic caught, and all kinds of people commented saying, I cut the injector in half, I pull it out this way, I do that. Um, when do you choose and how do you choose between these two types of sulcus lenses?
So I would echo what you say that the alternative lens is harder to inject. I think it's more finicky, and your videos captured many of the things I've experienced as well, putting the first cue in. So I think the Sulcoflex is probably easier to inject. Not that it doesn't have its own learning curve. And I've certainly done things like put the Sulcoflex in upside down and have to retrieve the situation. But notwithstanding that, I think the Sulcoflex is an easier device to implant. I find, rightly or wrongly, that the situations in which I use the first cue are those with a higher, or with more of an astigmatic component to the ametropia. And perhaps I'm attracted by the fact that there's 4-point fixation with the other lens. I don't know if it makes any difference, but I find in situations like that, if it's more astigmatic, I will tend to go for the first cue. If it's a more straightforward spherical error or a trifocal, I'll tend to go for the Sulcoflex.
Nice. And can I ask on that point of being a learning curve? I feel like part of my deal is I do talk about complications, perhaps too openly. I hope my patients aren't listening, but I have put these lenses in upside down by accident. And with the angulation, you don't want the haptics rubbing on the iris and causing problems. How do you get around that? I flipped one inside the AC and I think I'd probably damaged the endothelium. Would you explant and put one back in, or how did you deal with that problem?
So I've got an embarrassing story about that, and that was when
Excellent.
colleague, a colleague came to visit to watch me put in a Sulcoflex, and I said to her, "Whatever you do, don't put it in upside down." So of course, when I was doing it, I put it in upside down as she was watching. The tricks that I've found to avoid it are to not put too much viscoelastic in the injector to really minimize that, which may sound counterintuitive, but it seems that if there's too much viscoelastic, there's a possibility for the lens to torque in the injector. So less is more in that situation. I found it very useful to have a Sinskey hook going through the paracentesis to guide the first haptic, so that as the optic is unfurling, you can just press down at the right place to make sure that it goes the way you want. And finally, if it does flip and it does come out upside down, not to panic, just to let it sit there and then to formally explant it by bisecting it, which means having a backup lens available. And I think knowing that there's a backup lens on the table just gives me the confidence to say, if it's upside down, I can fix it. And of course, it's a very easy lens to explant. It's already sitting in the AC. It's very, very safe. So that's how I approach it.
Oh, that's good to know. It's also good to know I'm not the only one. Prof. Amon, do you have any other practical tips for when you are injecting the lens or using it? Things like how to dial it beneath the iris, or, do you inject it into the anterior
I
chamber?
have some practical tips, definitely. First, I would it's important when you fold it in the injector, Medicel injector, you bring press the optic a little bit downwards so that it is folding in the right direction. Sometimes it may fold in the other one, and then it may come upside down. Then I bring the trailing haptic on the optic so that it is not entrapped. And then I implant the lens, the first leading haptic behind the iris. And then the positioning is important. I now position, if it's not a toric lens, I usually position the haptic 90 degrees to the haptic of the other lens. of the back lens. Yeah, I think maybe there's more space or so. There's a nicer distance between iris and anterior surface. So I do it 90 degrees if it's not a toric lens. And it's important that you remove the viscoelasticum from the interface after implantation of the lens, because you avoid spikes of the eye pressure then.
Ah, that's really good. And Michael, we spoke a little bit about refractive surprises, and they happen to everyone. And even though I joked about you being an expert in sulcus lenses, they can happen to anyone. How do you decide when a sulcus lens would be the best option? Because like I said, there's laser, there's an IOL exchange, there's a sulcus lens. I know that for me, I love the sulcus lens because it's a quick recovery, it's predictable, it's simple. I'm not changing the eye particularly. I use the original incision. How do you decide when to do which one?
I have to admit my thinking's quite similar in that regard. It's, as you say, it's straightforward, and you're not altering another tissue as you would be with laser. But of course, laser vision correction is a very good option for a lot of patients, but it's not perfect for everyone. There are patients with dry eye or form plus keratoconus or frank keratoconus in whom you don't want to alter the cornea at all. And there's also the fact from a surgeon perspective, not everyone is comfortable using laser, not everyone has access to laser. But anyone doing cataract surgery has the option of taking the patient back to theatre and putting in a sulcus lens.
If you have a refractive surprise, you don't have to wait until the wound is closed. You can do that on the next day if you need, because you use that wound and you don't want to have it tight for your laser treatment. So I think this is one of the advantages with add-on lenses, that you can instantly use that and not later on only.
What's one key piece of advice you'd offer to surgeons who are new to using technologies like Sulcoflex? I know that's quite a tough question, but do you have one key Michael Rossiter Thornton pearl of advice?
It would be to just do it, just use it. So particularly with the example of the Sulcoflex, it surprises me how underutilized it is, considering how useful a technology and device it is. And I think our discussion has illuminated the numerous instances in which it can be used, and what that translates to is better outcomes for patients. So my advice would be find out about it, use it, and you'll be pleasantly surprised by the results. May I throw in a question? Is that all right?
Of course.
It's probably something that you and I heard about more, Ben, when we were training, but the concept of red rock syndrome, allegedly named after Uluru. So I remember when I was training, a lot of people said, the thing about sulcus lenses is you've got to be careful not to cause interlenticular opacification. But I've found as I've used them and as I've got more knowledge about them, it seems that interlenticular opacification is largely a thing of the past. So it might be one of those things that's holding back surgeons from using the lens, but I think it seems to be rarely a concern.
Interlenticular opacification did happen when piggyback technology in the 90s, where both lenses were implanted into the bag, and then from the equator, these lens epithelial cells grew into the interface. And this was really a problem, a big problem. In all my now more than 400 cases, I've never seen any interlenticular opacification. I think if you put the second lens into the sulcus, you avoid this problem, because the first lens closes and the lens epithelial cells are not able to grow into the center.
That's reassuring. That's really good to know, actually, because I was thinking the same thing, Michael, that you hear a lot about it, but I've never actually seen it happen.
No, because they are enwrapped in the bag lens, and then there's no chance that they will grow over. So some lens epithelial outgrowth at the rexis, sometimes you see one cell or two sometimes going there, but interlenticular opacification, which is a real problem, will never occur with add-on lenses in the sulcus.
Nice. Thank you. It's really good advice. Well, thank you to my two guests, Professor Michael Amon and Dr. Michael Rossiter Thornton. Such an interesting discussion about sulcus lenses and the Sulcoflex, from indications to tips and tricks to safely use them and optimize patient outcomes. I'm sure everyone listening will have learned a lot. That's it for today's chat on Rayner's Peer-to-Peer podcast, and I'll talk to you all again soon.